Before we get started, I just need to clear the air a little bit just so that you understand who you're dealing with. So go ahead and pull it up. I need to admit, as I mentioned yesterday, publicly, it's been verified, I don't sport. So if you wanted to discuss something other than sports, I'm good. If you want to discuss who my favorite team is, I don't have one. So I don't have a team. It's very un-American, but I don't have a team. And that's evidence right there. That's me being the umpire at the Reds game. The good thing is nobody was around, but it is up on the big screen. So here's my advanced slide, so I can do this myself. The other thing about me is that I like to take pictures of things. I observe people for a living, and I observe the surroundings that I live in. So these are just some of the funny pictures that I take along my travels that I find just to be really, things are odd, but you have to look at them. So I know that we're so busy going through life that sometimes you need to stop and just take a look around. So that's kind of some little bit of funny things there. So what I'm here to talk to you about really is about managing the big risk, and that is the user. So I do work at HS Design. It is a certified design firm. I do teach at the university. I like both worlds. Both worlds give me insights into a whole host of things. So, and given that I like to observe the world around me, it's pretty prime. HS is 40 years old, where we do a full service. We have engineers, designers that work there. But that's not why I'm here. I just want to kind of give you the context with which the lens that the world that I live in. I'm here to talk to you a little bit about the role of the user in risk management, how to uncover the user's abilities, their actions and attitudes in the design process, and then the application of human factors. So one of my other jobs is that I am co-chair of the AME Human Engineering Committee. So human factors and usability is near and dear to my heart. I'm an industrial designer by training, even though I teach biomedical engineering. So those are a little bit more about the background. So the role of the user of risk in risk management, first and foremost, if you don't have any use risk, you don't have any problems. If anyone here can name a device that doesn't have any use risk, the funny thing that I ask is, let's just think about a scalpel right now. Just a scalpel, plain scalpel. Would a scalpel get approved today with our current methods of risk analysis? A scalpel. I mean, it's one of those things where it would never get approved because you could never get rid of any risk. You could never mitigate all the risks associated with a scalpel, right? A user could use it for a whole host of things, including killing someone, which may or may not happen. Users are unpredictable, and that is the point, that you don't really know how a user is going to behave. You can predict it, and when we do our risk analysis, when we do our use risk analysis, we think of how all of the various ways could a user behave, but we're very creative as individuals. And the best example of our creativity that I can find is if I were to open up everyone's cell phone, the organization, the apps that you selected, we like to customize, we like to do things on our own. That is true in every person's being in their way of life. If a user performs a task incorrectly or fails to perform a task, this is a very good question, could it cause serious harm? And that's really what the agency is looking for, is could it cause harm? Now, the differences in my Amy hat when I look at the discussions between CDRH and CDER, for those that are in the pharma versus the device world, their definition of harms vary. So the definition of harm according to CDRH is, you know what? A little bit's okay. And that's why a scalpel stays on the market, because I'm going to inherently do harm every time I do surgery. There's no possible way I can do surgery without doing some level of harm. Whereas the pharma world says, nope, no harm at all. So we get into the combination device, it gets a little bit more and more increasingly complex, which means that you must pay attention to our use-based risk. So what does that mean when I start to do it? The first and fundamental thing about assessing the user and risk is that I have to know my user. I need to know them in and out. So if I don't know my user, I can't actually do an adequate risk analysis. It's just fundamental, and that means everyone. So good design is going to start with the knowledge of the user. What are their capabilities, their education, what's their training, what's their bias, how long have they been there? Is there a difference between somebody that has been working in the hospital for 6 months versus 10 years? Yes, of course there is. What are they? And how does that information impact the design? How can I bring in some of the disciplinary bias? So let me give you an example of what I mean by disciplinary bias. And we all have them. An anesthesiologist, if you were to spend a day with an anesthesiologist, you'd notice that they like to mix up medications and then they put it up. Then they give it to their patients. They have an entire box there that they will mix, and then they will administer their medications. If I give them an infusion pump that automates it, they don't actually like it. They like to mix it. That's a fundamental tenet of who they are. So they exist in everything, and it's about control because we like control. Hence, that's why all of our cell phones are different. So you get to the element of creativity, you get to the element of how we go ahead and execute how we execute our daily life and our daily practice. And it's true for all of our users. So why do you want to apply human factors? And I have these two pictures. This is from my academic world, and I think they're two pictures that are really, really telling. And the reason is because someday, God forbid, we may encounter the fact that we could be that person, or a loved one could be the person that's in that bed, that's in the ICU over there. And if you look at the number of screens that are available and the amount of information that's coming to that critical care physician, to that physician team, which is the picture on the left, that is a group of critical care physicians, residents, nurses, pharmacists, that are on rounds, and the amount of information that are going to these people is overwhelming, and they're going to make the decisions that impact their life. So the way that we need to think about human factors is really just making it easier for them to make the right decisions, harder for them to make the wrong decisions, and making sure that when we consider the patient at the end of the day, that we're making sure that they're doing the right work for their patients. I'd like for them to not really look at a screen, but actually look at the patient. That's kind of my thoughts. It's true throughout the hospital. This is an example of the amount of screens that you would find for anesthesia. And you can find complexities everywhere. If you look at the practice of medicine, it's abundant. Even when we bring devices to the home care, they're also complex. We're not following what I would say the IKEA model of instructions for use. You find them to be pretty elaborate. But this is just an example of some of the world in which we have developed. And one of the challenges that we have as device developers is that we look at our own device in isolation. We don't look at our device as part of an overall system, which is where we need to take a look at it from a very, very specific, here's my user, but here's the context with which it's used in. So when we design in context, it becomes a little bit easier, a little bit better for us to consider how that user is going to make that clinical decision. And we know from a business perspective that if it doesn't make a clinical decision making, that we don't actually have a product to sell. So we have to be involved in that clinical decision on the onset. Someone's going to prescribe our device, someone's going to use our device, someone may be the recipient of that device. So how do we uncover our users' abilities, attitudes, actions, considering, just when we talk about considering capabilities and limitations, we're talking really about how big they are, what's their age, what's the dexterity that they have, what are their training and education, their experience, their culture. When I talk to physicians, they could be trained in a specific organization, and that is why they do what they do. It's based on that training. They've always done it that way. It's not broke, don't fix it. And then age, as we're coming with more and more devices coming into the home healthcare, age becomes something we must consider, and that it could be a child that uses the device. It could be something as simple as how does the color go. Color and design goes beyond brand guidelines and preference. We have to consider, are they going to be colorblind? How do we distinguish elements for one thing or another? And that means that we have to get to user feedback and asking their questions and how do they respond to the designs that we put forward with them. So physical and sensory characteristics include vision, hearing, manual dexterity, strength, and reach. If you've ever designed a hand tool, one of the things with hand tools are, how do I actually reach all of the controls that I need to reach and in what order? I had the fortunate experience of working for Ethicon. It was Ethicon Endosurgery back in the early 1990s when we did pistol grips, and it was pointed out, hey, pistol grips for laparoscopic surgery are really ergonomically incorrect. So ergonomically incorrect meaning I am like this when I do my cases. And the edict was, why don't you just lower the table then, doctor? Well, they're used to it. Now they're accustomed to holding it up. If I went into laparoscopy today, I can demonstrate very easily that biomechanically, this is the worst position that I want my physician to stay in for 45 minutes. But it doesn't matter because that's how they're trained. That's exactly what it, and if I showed them something that wasn't a pistol grip, they probably would balk at it and I would negatively change it. So there's very much a learning, manual dexterity and strength. When I go like this, the reason why that's so bad is every time I have a joint deviation, I've negated my ability to provide the strength in pulling that lever. So how does that translate into the real world? Let's just say I'm back at Ethicon and I'm designing a linear stapler. And in order to get the linear stapler to fire 2 lines of staples and cut in the middle, I need to produce 75 pounds of force. call me on this lever, so all the engineers in the room can think about the math, right? It's inputs to outputs when I think about it from an engineering perspective. Well, I'm not physically able to do that if I'm a 50th percentile female. And the reality is that most people going to medical school are becoming increasingly women. So it was designed for men, but now it's for women. So that's when gender, size, all of the biomechanics come into play to impact the overall usability of a design. So it's important to pay attention to that. I find that element of design to be the easiest. There's a great standard. It's called AME HE75. It has all of that in there. That's the easy wins. What's more difficult are knowledge-based tasks, cognitive tasks where we are having to remember something. And that gets to the legibility and the discrimination. How do I hear an alarm? Can I hear an alarm over the top of what else is going on in the room? And I just demonstrated for you all of the complexity of the devices that are in the room. So how does one alarm sound versus another alarm? Can I provide more cues to those alarms? Can there be a visual with that auditory signal? And that gets to this perceptual and cognitive abilities. So our ability to detect and identify, recognize sensory input. Do I know that I have done something? What's my confirmation? Ever have one of those things where you hit the computer, you hit the button, and then you wait and you don't see anything, and you're like, did I do it? Did I do it? Well, what we do now is we do it again, right? So we are working right now on a device where we're just able to change training materials. This is a great example. And when the user hits the button, it's 2006 technology, and when the user hits the button, it starts to blink. What do we do when we see something blinking? We don't like that. It says I need to do something. Well, stop blinking. So I hit it again, and whenever you hit it again, it stops the device from working. So you get a use error because it's blinking. So those signals that we use, those cues that we use to navigate our way through life, are super important, and they tell us I've done something. They confirm back to us. It's important to pay attention to it. We'll go on to the next one. Expectancies. That's the established habits, the conflict that habits lead to use error. So if I know that I have a habit of doing something, then I know that I should maintain it. This gets to, if you were to design a car right now, imagine this world. You have free reign to design a car in any way you want to. It's going to have wheels and you're going to have to go. Well, imagine what would happen if I put the gas pedal on the left and the brake on the right. I have a use expectation. So globally around the world, doesn't matter. I get into a car, gas is on the right, brakes on the left. It's just something that we're going to do. You're not going to change up because you know that that is an expectancy. Well, as physicians, as nurses, as parents, we all have an expectancy. You have an expectancy for what you expect out of the conference, out of your life, and when things don't meet our expectations, we go, what's that all about? And we either like it or we don't like it, but when we think about it from a medical device and agency perspective, are we going to cause harm? Is there going to be an error that happens as a result of it? And that's because we develop mental models. We have the mental models of how our world's supposed to be. Those mental models are abstract concepts, and it's through an assessment of how users go through their life that you can figure out what their mental model is. And that's important in design because if I can get with them to conceptualize the operation of a new device that perhaps may have not been on the market, then I can walk through them with what their expectation is. So gone are the days can we sit there as engineers, as designers, and think that we are the user of the device. Well, I can do it, therefore they can do it. Well, all of my patients are dead because they were either dead to start off with or they were made of plastic. I will never do surgery. So I need to get their perspective, not my perspective, because their perspective is completely different than mine, right? Which gets to culture, diversity. Every one of the products that we work on is also global. When is it gone are the days that we only design for the United States, or we might say that we're designing for the US, but the intention is for a global market. So that gets into even more of what are the mental models when we take something and put it into a diverse world. So the great thing is that when it comes to mitigating use risk in terms of human factors, there's some fantastic guidance out there, and just point you to a couple of them. And you don't have a choice in this, so I'm sorry about that, but you don't, and that's our regulatory agency. So this is the most, this is from the FDA. It came out in 2016. It was first out in draft in 2012, stayed in draft for a long time. This is probably leading in the United States that they are expecting a human factors dossier. This document and this document, which is IEC 62366, they are written in concert with one another, so they will be alike between the two of them. If you meet that, you meet that. If you meet this, you may not meet this. So the difference between these two documents state that In the United States, you have to use United States citizens. That is the largest difference between the two documents. Both documents state you have to have user testing throughout your design process. They also state that at the end of it, you have to validate your users through a summative usability test, and they give you the instructions for what they expect in terms of a dossier that gets submitted, and they give you the report format. When you don't follow the report format, they don't like it, and they'll tell you that they don't like it, and they'll ship it back to you. This does not give you a report format to follow. This will tell you that you need 15 users, but it doesn't, it's not as strong of language as this. That makes sense because this came out after 62366 did. And then historically, this document here, which is from MHRA, is from the UK, and it talks specifically about the usability in combination products. And the difference between this document and these other two is a greater emphasis on instructions for use. And with that, that means that part of the user interface as defined by the regulatory agencies are the overall design, the graphic user input, the instructions that are given to the user, everything that would be available to them upon market release. So if training is part of your risk mitigation, then training is part of your user interface. And all of that has to be validated. The committee, the Human Engineering Committee that helps support this work here, there are a bunch of technical information reports on human factors engineering that is available to you that gives you a good methodology and best practices. So I highly recommend checking out that website to understand the background. And if you're not that familiar with standards organizations and how they work, the committee that I'm co-chair of, the Human Factors Engineering Committee here, votes on the international, we put the US position here. FDA is part of that committee. So FDA serves with us on that committee to make sure that everything is communicated back and forth. That doesn't mean that we always agree with the FDA. In fact, sometimes we don't, and we will argue in committee meetings with FDA because at that point in time, you're at a level playing field. It's the industry and FDA working in collaboration versus one organization coming up to the FDA. So a little bit of background there. You don't have a choice to not do human factors, but it's important to think about it in terms of who my user is, what are those attributes, those physical attributes, the characteristics, sensory, how do they think in the context of use. And so I'm going to share with you a case example of some of our work, which is in consumer health. It's a consumer health device. It's a device that, it's a vagus nerve stimulator. So your vagus nerve runs right here. The vagus nerve is one of those nerves that if you see people that had this happen to me, I heard about it yesterday, where one of my students passed out. That's a vagus nerve reaction. So your vagus nerve has all kinds of really great things. It's also the nerve that runs kind of all along your spine in here. It comes up to your neck. In this particular one, this vagus nerve stimulator, it's just new out on the market. The flow, the business model, the user experience strategy is that the physician writes a prescription, the pharmacy provides it, then the patient uses the device, they need a refill. It is an electronic device, so there's no drugs that go to it, and it just sends an electrical stimulation to that vagus nerves to relieve headaches. So, and what we did in this particular design exercise is we started off with working with different approaches to the whole product embodiment and do a workflow of what that user interface is going to look like, defining all the possibilities of how it could be configured, identifying the risk areas, the digital and physical use interactions. And then we started looking at how am I going to hold it? What's that user interface going to be? So this is really a great simple little merge of both physical buttons and digital user interface combined together. So what are all of the variations? And obviously you can get to quite a bit of permutations and what is a overall screen, where are the buttons located, and looking at combinations of both touchscreen and you know what I'm talking about. So then from here we built preliminary foam study models, and the users were able to take these study models and to match up what kind of graphic display and what kind of form is going to work for them. We believe in a participatory design process where we're inviting the users to give us direct feedback within our design process so that we're not designing in solo. We're actually arming the users to talk with us back in a way that we can communicate back and forth. And that's something that academically that my students struggle with, in that they'll go ahead and vote on designs that don't exist or have a conversation about designs. And we've all done that, where we've said, hey doc, or hey so-and-so, wouldn't it be great if we had a design to do X, Y, and Z? And you have a conversation, and and you think that you're understanding each other, but in reality, you have no idea. So if I had a car that made me breakfast in the morning that could help me put on my makeup, you'd have no idea what that really looked like in my mind, nor would I have an idea of what it looked like in your mind. But you could go ahead and brainstorm on it. But at the end of the day, we may not even agree. We may not even have the same idea in our minds. And so we have to arm our users with the ability to communicate to us how they're gonna perceive a particular device. From there, we did more formal usability testing. So this gets back into that jumping over from just doing the design to how do I get the users to really walk through that use scenario, walk through and identify the overall challenges that they may have. And what we discovered here was pretty interesting. We discovered that users may be sensitive to bright screens. So where we thought, put a big giant screen on here because I'm old and I can't see, that would help me out, actually are counterintuitive, because if you have a headache, you don't want to look at a bright screen. You don't want to see a bright screen in there. And depending upon the use environment, if you've been out in the sunshine, when you look at a bright screen, sometimes you can or you may or may not see, and so context is important. And so we were able to pivot the design direction based on the use feedback to give much more of something that's more realistic for and appropriate for this particular market, which is not to have a screen at all. But I forget, Tor, what's the technology this was designed with? I just threw that. He can't think of it either. There it is, it's that. Anyways, it's embedded underneath of it using lights. And you can see where it just became a much cleaner, much more simpler design than the preliminary designs that we had. What would you say? IMD. There you go. What does that stand for? Do you know? Yeah, IMD. Somebody does. It's such the afternoon. He needs a cup of coffee. So at the end of the day, this consumer product's out on the market. They use it once they'll end up using all the charges. This just tells them the number of charges that they have, the therapies that they have remaining, and then this gives that nerve signal to it. It's very successful, and they were able to design the packaging as well to just round out the whole use experience, so that that we were protecting from inadvertent damage on that on the electrodes. So in conclusion, when you involve human factors methods in your design process and throughout that design process, not only are you meeting your agency requirements, but it's also it satisfies your customer. So we've not gone to the part of delight. In consumer products, we want them to have a positive use experience. Well, why not have that in a medical device? And it doesn't matter whether it's a surgical tool or it's a consumer product. And at the end of the day, the goal is to improve life. I think the FDA want us to stay consistent. They want us to reduce risks and improve the lives of all the users. So it just sort of fundamentally makes sense. It's not that hard to integrate.
I think my lesson learned is if the speaker is a teacher, you're probably pretty safe. It'd be a good presentation. So thank you.
I don't know, because you know what? If you give them a marker, they may go on for a really long time.
No, not here. I would totally.
Yeah, you would get. You like gong them. Gong. Am I getting gonged? I think I'm getting gonged. I feel like.
How many?
Done.
What percent of medical device, either companies or products, would you say were designed without a solid understanding of human factors?
The entire world of catheter interventions. This is the craziest thing in the world. It's like asking you, Joe, to please take your garden hose and water the flowers next to your swing set while standing on your front porch. I'm gonna give you a few tunnels to do it, okay? So you figure out your tunnels. You have a map of the tunnels, but you have your garden hose, right? Because it's a skinny little catheter. I can only push it, pull it, twist it. That's all that I have. And I want to go and I want to water my wait, you know what? I want you to pick a flower out of your flower bed. It's your garden, to bring it on back around for me.
Okay, let me bring you back from the brink here. How about among products that don't have a 1975 predicate?
Okay. Newly designed?
Something after the regulations.
That hasn't, oh golly.
10%, a quarter, half, a third.
I would say we're better than, we're not too terrible. I'm going to go with half that have been designed. I would go with that. I would say at least half of them. And it really depends on the area that you're looking at. Because if you're looking at devices that are in the hospital versus home healthcare is getting a little bit more attention.
Okay. MB Privitera for you. HS Design. Thank you.
You're welcome.